Is that everybody? Um, Hi, I just want to say thank you for coming to our talk this evening. I know life is really busy with cold and flu season, and I do appreciate your time. Um, my name is Ann Luciano. I'm from the University of Michigan. I'm a nurse practitioner lead for a PAD multidisciplinary program. So I have the privilege of working with all departments who take care of patients with PAD. Because I do work with vascular medicine as well, I also see some patients with arteriopathies and thought I could give you a small introduction to um, arteriopathies and what might be helpful for a vascular surgery APP. I have no disclosures. So I just wanted to give an introduction to arteriopathy. Um, this is a group of disorders characterized by abnormalities in the arteries. It can affect the structural integrity of the vessel, causing dissections, aneurysms, or tortuosity. And it can also affect the function of the vessel, for example, with occlusion. Um, these are all common areas that we're very familiar with, the coronary arteries and the peripheral arteries. Just want to review normal versus abnormal function really quickly. Elasticity of the artery helps the arteries expand with the heartbeat and helps smooth out pressure fluctuations from the blood pressure. Endothelial function helps, it actually is the barrier between blood and vascular tissues. It plays a role in blood clotting, immune function, and controlling blood pressure by nitrous oxide. If these things are not working well, you can have complications, and those are aneurysms or weakening of the blood vessel wall, occlusive disease or stenosis, and hypertension. There are two classifications for arteriopathy. Um, Atherosclerotic arteriopathy is the one that we all know and love, and it's the most common form, characterized by a buildup of plaque that can lead to narrowed arteries. The non-atherosclerotic causes is what we're going to talk about this evening. Um, and it can include structural problems, defects or disorders in the vascular wall, inflammatory orders, autoimmune conditions that cause inflammation in the artery wall. Genetics can are inherited mutations that can cause defects in the artery. There are some infectious diseases that can cause inflammation and problems with the arteries. And there are other causes as well, like fibrosis of the artery. The risk factors for arteriopathy are well known to us. I'm not going to touch on the modifiable ones because I think we all know those. I just want to touch on the non modifiable risk factors as they speak to the non occlusive or the non atherosclerotic causes of excuse me, of arteriopathy. So age, these patients tend to be younger than what we normally see. They tend to be more often female patients. They can have genetic disorders, which can cause arteriopathies, and there are some ethnic groups that have arteriopathies. Environment and socioeconomic, we always need to think about for patients who have trouble getting to to appointments or don't have money for good lifestyle. Um, just kind of a brief overview. We want to think about things that are kind of outside what we normally do in the vascular world. We want a detailed family history, asking about other types of artery problems. For example, aneurysms or dissections. How old were people in the family when they were diagnosed with those? Um, we want to ask about past procedures, for example, dental procedures, any kind of joint procedures, poor wound healing requiring treatment, pectus or scoliosis surgeries. For social history, we want to ask about profession. Do they do a lot of lifting and straining, a lot of stress in their job? Are they smoking? There are some scoring tests that you can use that will help you diagnose arteriopathy. Rheumatology has a couple scoring tests, and then the Brighton score is an example of a test that we can use to test for hypermobility. Um, we it's important to have a detailed symptom questionnaire for the patient, not just cardiovascular symptoms, but for example, many of these patients have spontaneous pneumothorax. They may present with migraines or pulsatile tinnitus, lens dislocation. They may have scoliosis, joint dislocations, flat feet, poor wound healing, easy bruising, um, gastroparesis, hernias, and they may have disorders of the uterus and with bladder ruptures. Physical exam, most of us are pretty know the cardiac or the vascular physical exam, looking at all peripheral pulses, checking with bruits and palpation, looking for murmurs, which can um, diagnose valve disease. We want to do a musculoskeletal exam looking for scoliosis and joint function, looking at hypermobility. Craniofacial exam looking at the symmetry of the head. Doing a mouth exam looking for an arched palate, a cleft in the uvula, or dental crowding. And then the skin, easy bruising, thin, velvety feeling skin, and acrogerria is premature aging. We're all, I think, familiar with these diagnostic tests. Duplex ultrasounds are good for surveillance exams once patients have been diagnosed. The cons of the exam are inability to image the entire vessel, for example, the mesenteric vessels and having too much bowel gas, or the carotid vessels if the concern is high at the base of the skull. Technical expertise is also important, duplex exams. CTA, I think, is the gold standard exam for diagnosing arteriopathy. It has good spatial resolution. It's sensitive enough to look for um, dissections or aneurysms or thickening of the blood vessel wall. Unfortunately, it does have a little bit of radiation, and patients get quite a bit of contrast for these exams. So we need to think about that in patients who have renal insufficiency. MRAs are good for patients who can't have a CT scan. They are useful for aneurysms and dissections, less useful because of lower resolution for thickening of the blood vessel wall. Our angiograms are useful when a revascularization is planned, but they do have contrast and they are invasive tests. So management overall for arteriopathy, there's an acute phase, and this is usually when the patient is diagnosed. Imaging to diagnose the patient, and then medical management to manage their symptoms as they come in. Long term, we want to think about surveillance. How are we going to follow these patients? Surveillance and activity restrictions guidelines are different for each diagnosis. We want to think about family planning. Remember, most of these patients, or a great portion of these patients, are young women. And so there is often increased risk to the pregnant patient. So we want to think about multidisciplinary care with high risk OB-GYN during pregnancy and postpartum. These diseases are often genetic, have a genetic component. So we want to allow for genetic testing for early identification and treatment of not only the patient, but possible other family members. These are young patients, so we want to think about psychosocial needs for them, and then making sure the patient has the education that they need to take care of themselves for the future. There's a lot of arteriopathy non-atherosclerotic diagnosis, but I just picked a couple to kind of give us a flavor of these different categories. non-atherosclerotic, non-inflammatory diagnoses like fibromuscular dysplasia and spontaneous coronary artery dissection, connective tissue disorders like Ehlers-Danlos and Marfan syndrome, and then inflammatory disorders like Takayasu's arteritis and giant cell arteritis is what we'll talk about today. So fibromuscular dysplasia is a cellular proliferation of the medial layer of the artery. Pathophysiology is unknown. Thought that the arterial wall gets weak and then injured, and then the body tries to compensate for that injury by causing extra fibrous tissue in the vessel wall. It focuses on medium and small blood vessels, and there are two different types of FMD. One is the multifocal type, which appears like a string of pearls. And that's because there are areas of increased fibrosis in normal tissue, which gives you that bump appearance. That usually happens in the mid and distal vessel. FMD can also occur in the proximal vessel, and it looks more like just an aneurysm itself. This again happens in the medium and small peripheral arteries, so most commonly in the carotid and vertebral arteries and renal arteries. Excuse me just a sec here. The incidence, 80% are mostly in women, younger age, 40 to 50. When should you suspect FMD? These are young patients, less than 35 years old, who have drug-resistant hypertension. And drug resistance is defined as an elevated blood pressure above goal, despite the use of 3 or more antihypertensive medication classes, traditionally ACE inhibitors, ARBs, and diuretics. Interestingly, drug resistance is also defined as a patient who achieves a target blood pressure on 4 or more antihypertensive medications. These patients have a rise in creatinine, or can have a rise in creatinine when you give them ACEs or ARBs, and they often have an abdominal bruit. Patients less than 60 years old without the traditional atherosclerotic risk factors, who have a carotid bruit, a stroke or a TIA, or an aortic aneurysm. Sometimes these patients come in, or we're asked to see them as a consult for headaches or tinnitus or dizziness. They can have peripheral or coronary aneurysms and renal infarctions. Presentation is based on which arteries are affected. So patients with renal FMD often have early onset drug-resistant hypertension. Patients with cerebrovascular FMD can have migraines, pulsatile tinnitus, stroke, or TIAs. Mesenteric FMD can present as intestinal angina. Those patients have postprandial abdominal pain and weight loss. And then FMD in the extremities typically presents as claudication of the extremities. CTA is the preferred imaging diagnosis for CTA is a preferred imaging to diagnose FMD. Treatment for FMD or lifestyle modifications, as we normally do, moderate aerobic exercise, low sodium diet, smoking cessation. You may consider antiplatelet, aspirin, 81 milligrams for stroke prophylaxis in patients who have carotid FMD. Blood pressure control, goal of less than 130/80. First line drugs are ACEs and ARBs. Second line drugs are diuretics, calcium channel blockers, and beta blockers. Revascularization is required in a small portion of patients, and that is dependent on symptoms. So those patients with difficult to manage hypertension and renal dysfunction. So the goal of long-term surveillance is to prevent renal atrophy and chronic renal insufficiency. So patients with renal FMD we need to follow their blood pressure, follow their lab work, their creatinine, and get renal ultrasounds. Spontaneous coronary artery dissection is a non-atherosclerotic, non-traumatic, non-iatrogenic acute coronary event relating to the development of a hematoma in the coronary artery wall that results in compression of the artery, which leads to ischemia and MI symptoms. There are two different thoughts about the pathophysiology of SCAD. One is outside in, where the hematoma develops in the wall and compresses and pushes the artery in, causes stenosis or compression. Inside out was where there may be an intimal tear causing a dissection of the artery, which then causes occlusion or compression of the vein. 80% of these patients are female. Age, again, more common in the 40s and 50s. The studies for these types of patients are small, so most of them are white, but a small hint that Hispanic and Mexican patients are affected as well. So for acute coronary syndrome, patients have hypertension, hyperlipidemia. These SCAD patients, only about 25 to 30% have hypertension or hyperlipidemia. They more have the non-cardiac causes, which is stress. And, sorry, excuse me. And stress is important in this diagnosis. Men tend to present after heavy workouts. Women tend to present after increased emotional stress. When should you suspect SCAD? These are patients young patients who have no cardiovascular risk factors that present with acute coronary syndrome or myocardial infarctions. Often, these patients describe a history of migraines or anxiety and depression. Women have significant emotional distress. Men complain of heavy workouts, and then some of these patients may present during or in the postpartum period. When you take the history for a patient with SCAD, again, migraines, early age hypertension, pulsatile tinnitus, and increased stress. And you can see in the little diagram here that emotional stress, medications, Valsalva, intense exercise kind of combine to, add on to the traditional risk factors for SCAD. These patients present similarly to somebody with acute coronary syndrome. So they all have chest pain, nausea, emesis, dizziness, and fatigue. Their EKG shows acute myocardial infarctions, ventricular arrhythmias. Because of the ischemia to their cardiac wall, they often have biomarker elevations, and then an echo shows LV dysfunction. The imaging of choice for these patients, because they are an acute coronary syndrome, is a coronary angiogram with IVUS, echoes, and cardiac CTs. In the acute phase, the focus is to preserve myocardial infarction. Conservative management, 80% of these patients are treated successfully with just medication, and the majority of their lesions heal spontaneously. Revascularization has high failure rates, as well as increased MACE during the hospital and follow-up. Revascularization should be reserved for patients who are in cardiogenic shock, have malignant arrhythmias, or severe left ventricular dysfunction. For those patients who are pregnant, The focus is to preserve maternal and fetal outcomes, and we do want to consider radiation exposure with these patients. And then the follow-up phase, conservative management. There are no guidelines for the care of SCAD, so you follow the guidelines based on the care. So if the patient has LV dysfunction, you would follow the heart failure guidelines. If they were treated with angioplasty or stenting, you follow the post-procedure antiplatelet guidelines. These patients should be continued on an aspirin and a beta blocker with follow-up imaging at intervals based on symptoms. Long-term management for these patients, you want to assess for concurrent arteriopathies. 1% of patients who present with an MI have FMD, but 50% of patients who have SCAD have FMD. These patients all have chronic chest pain, so it's often non-exertional. It occurs with stress or perhaps when patients are having their menstrual period. It commonly occurs in the absence of SCAD reoccurrence or progression. Unfortunately, it causes frequent rehospitalizations and testing, and not typically angiograms, but more by biomarkers, EKGs, and CT and echo stress tests. These patients are often fearful of physical activity, so cardiac rehab is really good for them. It's very reassuring to them, and it actually promotes good long-term outcomes. They all have lifting restrictions. These patients are young and have lots of anxiety and emotional stress, so it's important to address their psychosocial and mental health concerns, reproductive concerns because we don't have a test that says, yes, you have SCAD. Patients are often advised not to become pregnant. If patients really feel strongly about becoming pregnant, we recommend a multidisciplinary team with high-risk OB-GYN. Most of these patients, yeah. And then the prognosis for this is very good, less than a 2% risk of long death in the future. So they do well if we can get them past their first episode. Oh, and I just want to say, I know that it doesn't make sense to present a coronary artery arteriopathy to vascular people, but I think you may see some of these patients because they're going to be consulting you to look out for other current arteriopathies. And so you want to think about FMD, and you want to do a head to pelvis CT scan looking for FMD. If they don't have FMD, then you don't need to see them back. If they do have FMD, then you probably want to do a scan in 4 to 5 years just to make sure they don't have aneurysmal degeneration of their FMD. Vascular Ehlers-Danlos syndrome is a connective tissue disorder. It's a mutation in the COL3A1 gene that codes for collagen. Collagen strengthens and supports tissue, particularly in the skin, lungs, intestine, and arteries. It is autosomal dominant, which means that if one parent is affected, the children have a 50% chance of being affected. 1 in 50,000 people have this disease. They often have major complications at age 30, and the mean survival is approximately 50 years old. These patients are usually initially diagnosed by having rupture of hollow organs like the bladder or the uterus, or rupture of arteries with or without aneurysms, particularly in the abdominal and groin area. They can have recurrent joint dislocations, tendon and muscle ruptures. Most children are diagnosed by age 18 because they have a family member who's positive, or because they have a serious event. Those children who are diagnosed that don't have a serious event often have distal joint hypermobility, easy bruising, thin skin, and club feet. So when to suspect vascular Ehlers-Danlos, these patients are younger than 40 years old that have an episode of arterial, uterine, or intestinal fragility. If you look at these pictures, these kids have thin lips, long, thin noses, deep set eyes. They have a flattening between the eyes and the brow. They have thin skin and attached earlobes. So most of these patients present with sudden extreme pain from an arterial rupture, a dissection, or intestinal or lung perforation. Most of the management, if the patient is asymptomatic, there are no guidelines, and we recommend a multidisciplinary team for management. For symptomatic patients, surgery is often recommended. And then long-term surveillance referred to genetic counseling for family counseling, and testing, and then screening by imaging at intervals based on the patient's symptom. Long-term management for patients with vascular Ehlers-Danlos, no strenuous or contact sports, no heavy lifting. They can do regular aerobic exercise, moderate aerobic exercise. Brass instruments cause increased pressure in the lungs and blood vessel. So we recommend alternative instruments for those who are in school. With pregnancy, there's a 5% risk of mortality with each pregnancy based on the high risk of blood vessel or uterine rupture. We recommend maternity leave at 30 weeks, and C-sections are often recommended at 36 to 38 weeks to prevent complications. Avoid surgeries or procedures with these patients because that just makes a higher risk of perforations. And then we recommend testing all relatives. Follow up, if patients are doing well, they can be screened every 18 months and with a multidisciplinary team. The other genetic syndrome that I wanted to talk about was Marfan syndrome. This is a mutation of the FBN1 gene that codes for fibrillin 1, and this is also a connective tissue protein that strengthens blood vessels. It occurs in one out of every 3 to 5,000 people without a preference for race or gender. Most of these patients are seen for aortic root or aortic aneurysm. They can also have mitral valve prolapse. The primary cardiac problems are the primary cause of morbidity and mortality in 60 to 80% of the patients. They can have skeletal deformities, long limbs, scoliosis, pectus deformities, and they can have a lot of eye issues, lens dislocation, cataracts, and retinal detachment. Diagnosis is by genetic testing and imaging of the aortic root. Again, this is an autosomal dominant genetic mutation. So patients with Marfan's, when to suspect a Marfan's patient, somebody you might see who has aortic root dilatation or dissection, retinal detachment, the skeletal findings such as long arms, legs, and fingers, or a tall, thin body, a curved spine, spontaneous pneumothorax, flat feet, skin striae. Surveillance is cardiac imaging, often baseline in 6 months to determine the aortic growth rate, and then yearly. that we recommend beta blockers and ACE inhibitors to keep the heart rate less than 100. This reduces wall stiffness, decreases growth of the aorta, and it's thought to improve the elastic properties of the aorta. There are restrictions of vigorous physical activity and genetic counseling. Management is elective repair of the ascending aorta and valve replacement as soon as the aorta reaches 5 centimeters. Postoperative care, they may need anticoagulation if they have a mechanical valve replacement. And you want to avoid medications like fluoroquinolones and calcium channel blockers, as those are thought to increase aneurysm growth. Now we're going into the inflammatory conditions. Takayasu's vasculitis is vasculitis or inflammation that's thought to cause fibrous thickening and endothelial dysfunction of the arterial walls. It causes damage to the large and medium arterial vessels, like the aorta and its major branches, such as the renals, carotids, and subclavians. This occurs in young 40 to 50-year-old females of Asian and Mexican descent, 1 to 2 patients per million, and females are 9 females to 1 male. Symptoms, there's often an acute inflammatory phase where patients have fever, malaise, weight loss, poor appetite. Most patients aren't seen during this phase. They typically are diagnosed during the late phase. It's also called the pulseless phase because these patients come in with symptoms related to occluded arteries. Physical exam and history is important for these patients because they are so young, and then imaging by CT scan. The American College of Cardiology has a scoring for Takayasu's arteritis, and you can see that you get more points for having more artery territories and having symptoms of having decreased pulses. But again, these are young females who have symptoms of symptoms of symptoms of blocked arteries, but have no risk factors for blocked arteries. The initial treatment is medication. These patients are put on corticosteroids, and it has been found that if you use corticosteroids with immunosuppressive medication, that gives you better outcomes than steroids alone. You can put these patients in remission, which is considered absence of vessel inflammation, but more than 50% of patients will have symptoms that return or progress. For revascularization, endovascular is limited given the fibrous stenosis of the arteries, so surgery is often recommended. And it's recommended not to bypass or attach bypasses or anastomosis into areas of the artery that are affected, because that gives poor long-term outcomes for the bypass. For long-term, these patients need serial laboratory studies for inflammation, and they get treated based on those lab studies, serial imaging, and then often about 25% have activity restrictions from their stenosed blood vessels. The last syndrome I want to talk about is giant cell arteritis, and this is a vasculitis where inflammatory cytokines and T cells are released into the blood vessel wall. This occurs in medium to large vessels. It's thought that vascular aging plays a role in the initial immune activation. This is the most common form of vasculitis, 10 patients per 100,000 over age 50. Women, 2.5 to 1 male. And the symptoms are mostly in the head, new onset headache, scalp tenderness, claudication of the jaw. You can have a lot of visual symptoms, constitutional symptoms. These are what I would call rheumatology symptoms: fevers, night sweats, fatigue, depression, weight loss, stiffness of neck and shoulder, and then when to suspect giant cell arteritis. Think about the older woman who smokes and is skinny, has a history of vascular disease or polymyalgia rheumatica, and is of Northern European ancestry. Excuse me. Diagnosis is, while there's no criteria to diagnose GCA, there are some scoring there are some scoring tests, but they're on the web, but those are validated for research purposes only. So laboratory work for inflammation, CRP, SED rates, platelet counts. Temporal artery exam is becoming the gold standard exam. It's a duplex of the temporal artery, where you can see diminished pulses, tenderness, or cord-like structure of the artery. Biopsy is the gold standard, but it is invasive, and you have to send it to the lab and wait for the results. So more people are doing the temporal artery exam. For difficult to image vessels like the thoracic aorta, you can use CT scans, and the treatment is immediate high dose steroids. And steroids can be adjusted depending on how the patient responds. And then you want to make sure you have a fast track referral service to ophthalmology, because with the eye symptoms, you can have high incident of blindness. So I think the take-home points for this talk is consider an non-atherosclerotic arteriopathy for young, mostly female patients who present with arterial dysfunction, who do not have the traditional risk factors that we're used to. It's important to do a comprehensive history and physical exam, looking at not only the vascular causes, but also musculoskeletal and GI and other causes. Imaging for surveillance and diagnosis is important, with the CT scan being the gold standard test. Treatment needs to be individualized, given the disease complexity and risk for future complications. Conservative management is often preferred. Most of these patients get blood pressure medication and antiplatelets, along with surveillance imaging. And then procedures are reserved for lifestyle limiting or life-threatening symptoms. All righty, I think that's all I have.
Amazing work, Anne. Can you hear
Thank
me?
you. Yeah.
Awesome. And I apologize, I wasn't able to log on quick enough to introduce you.
Oh, no
Um,
worries.
Anne Luciano, am I pronouncing your last name right?
Yeah.
Has quite the robust resume, but I'm going to be brief with her introduction after she gave a phenomenal presentation. She is the NP lead for the PAD program at Michigan Medicine. She has worked there, let's see,
But
um,
really
2018 to
35 years,
current.
I think.
Yes, a long time. Um, and she's a very robust, obviously, NP and nursing background, specific to cardiac and vascular. She's given multiple presentations related to cardiac and vascular, heavily involved in Society of Vascular Nursing, and she's also involved in Society of Vascular Medicine. She has several publications and abstracts that she has submitted over the years. So And thank you so much for speaking this evening, for your expertise. I did want to say she summed up about a million topics into one presentation.
Yeah.
Um, and so kindly asked that I kind of go over. I submitted a manuscript specific on arteriopathy management, led by a vascular medicine NP. And it's such a loaded topic with lots of different nuances. And Anne did a great job of describing each as best she could. And to be frank, there aren't a load of guidelines. Obviously, acute coronary syndrome secondary to atherosclerosis, we have a lot of guidelines when it comes to SCAD, when it comes to fibromuscular dysplasia, when it comes to spontaneous cervical artery dissections or visceral artery dissections. There's a lot of unknowns. And so, and with her expertise, the manuscript I've submitted to our personal journal hopefully outlines kind of a framework for you all to follow to the best of our abilities and what's out there. There is going to be more research. I personally worked with an attending, Dr. Esther Kim, who was pulling blood from SCAD patients to be able to have a biomarker for when they present to the ED, because a troponin is not specific enough to say if a patient had a SCAD or not. And then they obviously go for a cath, and sometimes these patients can be mistreated if the physicians or interventionalists don't know what they're dealing with. So I'm so passionate about this patient population, and I know there's so much more to learn. The framework that I submitted to our journal includes an introduction of the framework and then goes through all the common arteriopathies that Anne presented this evening. So fibromuscular dysplasia, cervical artery dissection of unknown cause, spontaneous coronary artery dissection, visceral artery aneurysm and dissection, and then connective tissue disorders as a whole separate topic. And all of these I listed kind of patient presentation, diagnosis, treatment and surveillance. And then I have a whole separate section on kind of how do you evaluate these patients? You know, how do we address physical activity counseling, family planning, everything Anne listed. So this document is at everyone's fingertips that joined this roundtable. And obviously Anne is a valuable resource for all of us. And we open the floor to questions. I did answer Brittany's question. FMD cannot go away. This is something that the patient has and will have forever. So I think to answer your question, maybe it was never truly FMD to begin with. Patients usually, they're either found incidentally with FMD with imaging, with maybe a carotid ultrasound screen or an incidental finding on a CT scan. And a lot of those patients, let's say they're older than 75, have lived with this condition their whole life and never had a symptom. And then on the flip side, it's almost like a spectrum. You can have a 25-year-old presenting with a stroke due to cervical artery dissection secondary to FMD, or spontaneous coronary artery dissection secondary to FMD. So wide range of symptoms and presentations and lots to learn. But like I said, we're opening the floor to questions and look forward to hearing from you all. I think everyone's shy just because it was such a great presentation. They don't have any questions. And don't forget to take the post test now for CEU credit. You must receive a 70% or higher in order to claim credit. Hopefully the questions aren't too tricky. And do you have any knowledge to share or anything else you want to add?
Yeah, no, I just think the big take home thing for the vascular surgery APP is that you're going to see these patients to diagnose, people might have a specific diagnosis. For example, you might see a patient with tinnitus or dizziness, and they want to know about, do they have carotid stenosis? And you're going to evaluate this patient, and they might have FMD. So just kind of keeping those things open in your toolbox and being aware of diagnoses so that you can accurately diagnose the patient is going to be
So,
important, I think.
and Anne, don't you think that people are becoming more aware of what
Oh,
FMD is?
yep.
And so
Hmm.
they come to your clinic like, do I have FMD? I hear,
Yeah.
tinnitus, or
Yeah.
I have high blood pressure at a young age. And um, so I think it's gaining more recognition and momentum. And so to Anne's point, it's so important to be able to accurately understand how to diagnose these arteriopathies accurately. And then when to, hey, you have FMD, maybe we should think about screening your family members.
Hmm.
When does that come into play?
Yeah.
I have Amelia saying, great presentation, not easy to summarize, but you did it. I totally agree. I do not see many new patients, but now I have a better awareness for complaints that do not add up. Now you know who to send them to, Anne in
Right.
Michigan. I
Happy to help.
love it. All right. Well, maybe we give everybody about 1 more minute to ask questions and then kind of wrap things up. How does that sound? Joanna, do we typically stay on until 7 or how do we handle this?
We can
Oh,
log off whenever you're ready, but there is a question in the Q&A box that was
yep.
submitted about a minute ago.
Yep. Courtney Davis, do you have any advice for a new NP starting in vascular? And you want to take that first?
Sure. Um, I think it's really important to make friends with people outside your department. So if you're in vascular surgery, seek out the NPs who are in vascular medicine, interventional cardiology, interventional radiology, um, as well as vascular surgeons, because those people are that you can always go to and ask a question. My partner does vein disease, and I do not do vein disease, and I'm constantly asking her, hey, did I do this right? Or hey, am I thinking the right way? So the more people you know and have in your as backups, the better a nurse practitioner or APP you're going to be.
Yeah, I can kind of dovetail off of Anne's response. I started as a new vascular NP, alone as an NP on the team. And so worked with 3 attendings. And over the 6 years that I worked on that team as solo NP, I felt alone the first year until I joined SVN and Society of Vascular Medicine. I think building that network of like APPs around you is so, so pivotal. Obviously, Anne this made a great comment that you want to surround yourself with specialties that you kind of collaborate with and share patients with as well. But the vascular APPs can provide orientation manuals, they can provide education tools, you can share cases together. And so I highly encourage almost asking for a mentor, and we can do so through this society to kind of help you get acclimated because it's definitely tough and lots to learn. Of course. Courtney, if you don't mind sharing your email, we can follow up with you. Thank you. All right. Thank you all so much for joining. And anything else to add?
Nope, I really appreciate your time.
Yeah, we appreciate your time. You spent a lot of time on this presentation.
Yeah,
You should definitely save it and present it on a different platform. It was great.
I'll do that. And what's our meeting for next month?
Great question. Joanna?